Good evening, and thank you for the opportunity to speak in this webinar. It's a real honor to be able to be a part of this. My name is David Shearer. I'm an orthopedic trauma surgeon here at UCSF, and I have a subspecialty practice in trauma and foot and ankle surgery. I'm going to be talking about how to avoid failures in tibial plafond fractures. No disclosures. And when I got this topic and I started to think about, how do plafonds really typically fail? And when I thought about that, these are really the three main areas I think that are the most common problems that we see. So the first is at the wound with infection or wound breakdown. The second is the joint because of post-traumatic arthritis. And then the third is in the metaphysis through metaphyseal nonunion. So I'm going to focus this talk really on each of these three issues, and we'll use a few case examples in order to illustrate some of these points. These are really kind of the main learning objectives. The first, to avoid infection, we want to use a staged approach and meticulous soft tissue handling. To prevent post-traumatic arthritis, we have to develop a really thoughtful and careful preoperative plan in order to achieve an anatomic reduction, which will not eliminate the risk of post-traumatic arthritis, but certainly can reduce the risk. And then we'll talk about a bit about the metaphysis, the importance of restoring alignment and an appropriately applied buttress plating. We'll start with a bit about the wound and how to prevent infection, which is through staging. And this is kind of one of the first key points of the talk, is that staging followed by definitive ORAF has become the gold standard really for the treatment of the majority of pilon fractures. The first stage is the application of external fixator that spans the ankle joint and restores length, rotation, and alignment. This allows for the delay of definitive surgery until soft tissue swelling allows, which is typically 10 days to 3 weeks after injury, but it really just depends on what the soft tissue envelope looks like. If it's a high energy injury with a lot of blistering, sometimes it can take quite a bit of time, which is why it's really, really important to apply a really good external fixator. So here's just a case example. It's a gentleman involved in a motorcycle crash, has a comminuted tibial plafond fracture. You can see in the splint, there's just no way he's going to be held out to length or an appropriate alignment. And so you've got to do something to temporize this until you're ready to do definitive treatment. This is kind of my sequence for doing an external fixator. First, I place a pin very proximal in the tibia. You see the red dot there. And then I want to make sure that pin's nice and proximal and out of the way of future plates. You can't always avoid overlap with your external fixator, but I think if it can be avoided, it's preferable. Then place a transcalcaneal pin, and that's going to allow you to build this delta frame like this. And then using this frame, you can apply traction. And in this case, because of varus pilon, we'll apply a little more traction on the medial bar. And that's going to give us a much better alignment and get us out to length. Once I'm at this point, I'll drop another pin proximally into the tibia, and that kind of locks in the frame. And it also can be used to fine tune the sagittal alignment. So I'll come to the lateral view and I'll make sure that I get that view correct. And this is what it looks like at the end. The goal is that you've got the talus centered under the tibia on the AP and the talus centered under the tibia on the lateral. A nice landmark for that is the lateral process of talus, which ought to be centered, but is pretty close to the center of the talus. The other thing I wanted to highlight on this is I always place a cuneiform pin as well. The cuneiform pin can help you control the dorsiflexion, plantar flexion of the ankle. You don't want to leave these people plantar flex for a prolonged period of time because it can really increase the risk of equinus contracture, especially if they're sitting in this for 3 or 4 weeks. This is what a clinical photo of it looks like. So again, you see the two pins in the tibia, the transcalcaneal pin, and then a cuneiform going from medial to lateral. I'm not going to belabor the pin placement, but again, 2 tibial pins, which are just placed by palpation in the tibia. And then the 2 distal pins I place using fluoroscopy. The calcaneal pin, I try to keep nice and posterior where it's safe, away from the neurovascular bundle. and then a cuneiform pin that just goes right across the three cuneiforms. So there's always a bit of controversy about whether to fix the fibula at the time of external fixation. I personally am a fan of doing it if under the right circumstances. The reason why I like doing it is that it really increases the stability of the construct, which I think leads to better soft tissue rest and sets you up better for your second surgery. It really helps you dial in that length and alignment in particular. And then it's also just one less thing that you have to do at the time of a definitive surgery, which is sometimes can be a long case, and it's nice not to have one less bone you have to fix. However, I would say only do it if you'll be the one doing the definitive fixation, because you want to, there's got to be some, you don't want to disrupt the subsequent surgeon's surgery. So if you're working in an outside a hospital where you're just going to be the one that does an X-fix, and then you're going to either send it to a partner or to another hospital for definitive treatment, do not fix the fibula. And then only if you are the one that's going to do it, only do it if you feel like you can anatomically reduce the fibula, because if you fix it short or malreduced in some way, you can make it almost impossible to reduce the tibia, and it will be even harder. So if it's really comminuted, or if you're having a busy day, or it's the middle of the night and you're not going to be able to spend the time to get it right, then don't do it. If you do it, make sure to use a posterolateral approach. The reason it's a little bit more forgiving from a soft tissue standpoint, because you've got muscle coverage over the plate, and it doesn't prevent you from doing any of the other approaches. So you can still do use the same posterolateral for the tibia. You could also still do an anterolateral approach. So one of the reasons, just to illustrate the point of why it's nice to fix the fibula, it's really hard to tell in this whether the length is appropriate, and I think it's probably a bit over-distracted. And once you fix the fibula, it becomes clear that it is over-distracted, and you can let a little bit of traction off. So here's another case example. This is another comminuted tibial plafond fracture, more of a valgus type pattern. Again, he goes into an external fixator. Actually, this one was done at an outside hospital and referred into my practice. But I think that a very reasonable job was done. You'll notice they didn't fix the fibula, which is I actually appreciate. And so now we've got to come up with a plan. So here we're going to focus into the second learning point, which is how do you come up with a good preoperative plan to achieve an anatomic joint reduction? And it really does just start with spending a lot of time coming up with a good plan, scrutinizing your CT scan, and making sure you really truly understand the fracture. So first I look at the x-rays, of course, and scrutinize them, and really with a couple of goals. I just want to understand, is it a B-type fracture or a C-type fracture? And by that I mean the AO-OTA classification. Is it partial articular or complete articular? And then if it's a C-type fracture, which is the majority of cases, I want to know if it failed in varus or valgus, and that just helps me understand where the tension failure was and which side failed in compression, because that side that failed in tension is often going to be a little bit simpler fracture pattern. It's often an easier place to start with my reduction sequence. This is what the axial CT scan for this patient looks like, and you can see P1 fractures break in a very predictable pattern based on the ligamentous attachments of the ankle joint. There's typically an anterolateral fragment, a posterolateral Volkmann fragment, and a medial malar fragment. And they each have a ligament, and then there's some often central impaction between the three. The red lines here are showing the ligamentous attachment. So the anterolateral fragment is attached to the AITFL, the posterolateral Volkmann fragment's attached to the PITFL, and then the medial malar fragment's attached to the deltoid ligament. So it's important with whatever approach that you choose that you don't strip these ligaments off obviously, number one, because they provide stability to the ankle, and number two, because they also supply blood supply to these fragments. So you can move these pieces around, but it's provided that you're hinging on these ligaments. One of the more important things that I always look at in selecting the approach is where does the fracture line exit anteriorly, because that often helps deciding between the couple of the more common approaches. So when you're thinking about approach, you can really come at the ankle from any direction, but I would say that the workhorse approaches for most pilon fractures are the anterior approaches, either anteromedial or anterolateral approaches. And then the question is really whether you want to add an adjunctive posterior approach. So posterolateral, or in rare cases, a posteromedial approach in my practice. This is how I do the anteromedial approach. Typically, it's an extensile incision that actually, the vertical limb is actually lateral to the tibial crest and comes down over the anterior compartment, and then at the level of the ankle joint, it curves medially. This is a very, and you're just sweeping the entire extensor compartment medially. This is a very, gives you very good exposure of the tibia. You can see the whole medial malleolus. You can reach all the way around, often to that posteromedial fracture line. And you can see most of the way onto the anterolateral fragment, although you can't really get into the lateral gutter or the proximal isomy or the syndesmosis. So that's really the limitations of it. It is an extensile approach, so you can extend it proximally as much as you need. But the downside is really the wound healing issues with this approach. So it's a higher risk approach from a wound healing standpoint because of that corner. You can get flat necrosis there, and so it's definitely a high risk approach. You want to make sure soft tissue swelling is completely subsided, there's no blistering, and you've got the right patient. The anterolateral approach is the other common anterior approach that I utilize, this is shown here. You do have to deal with the superficial perineal nerve, which you can see in the image on the right there. So you just have to dissect that out and be careful with it. You can see this is it's a nice exposure of the lateral part of the tibial plafond, but you really can't get over to the medial gutter or the medial malleolar fragment. So it's definitely less exposure than what you get from the anteromedial approach. It's not extensile because the anterior compartment muscles cross, are heading laterally as you go more proximal, and so you can't really go very far proximal with it. So what's shown here really is kind of the extent of the incision. But it's much safer from a wound healing standpoint than the anteromedial. And if you have a more lateral, a fracture line that exits more anterolateral, you'll have a really nice view of it with this approach. It's also pretty nice approach to put an anterolateral plate in because you're coming down right on where the plate, where the screws are going to go into the distal tibia. The third approach that I'll talk about is the posterolateral approach. This approach is described as being right on the posterior border of the fibula, or classically described as between the fibula and the Achilles. I typically do it right on the posterior border of the fibula. I come down on the perineal tendons, and you can work anteriorly to get to the fibula and posteriorly to get back to the tibia. Here's what it looks like clinically. You can see there the right over the perineal tendons, and then if I pull the tendons posteriorly, I get to the fibula, and if I pull them anteriorly, I get a nice view of the tibia there. In this case, this is a case where both the fibula and the tibia were plated through the same incision. So how do you choose which approach to do? So I already said it, and I'll just say it again. For the fibula, always do posterolateral because you'll have access to the fibula or the tibia, and you you still have an adequate skin bridge to do an anterolateral approach. For the tibial approach, so it depends. So for a C-type pilon, so complete articular, I either do an anteromedial or an anterolateral, based primarily on where the anterior fracture line exits. So if it exits medial, I'll do an anteromedial. If it exits more anterolateral, I'll do anterolateral. And I'll only add a posterior approach to the tibia if I need it, generally for either the posterolateral fragment reduction or for the reduction between the posterior and the medial fragment. But I try to avoid doing two approaches to the tibia if I can. For a B-type pilon, I just make the approach directed towards the apex of the fracture. So if it's an anterior B-type, then it's an anterior approach. If it's a posterior B-type fracture, then I do a posterior approach. So it's really just directed by where the apex of that partial articular fragment is. So now we'll go through the reduction sequence for this case, and it's not always the same sequence. This is kind of a classic sequence though, and I think it does work for a lot of cases. So begin with the fibula to get our initial length, and then we do the posterolateral fragment, the medial fragment. We can then still access and reduce the central impaction, and then finally the Chaput anterolateral fragment last. So here's that same case I was showing you. So we start with the fibula. We try to get it as anatomic as we can. This now you can see the talus is out to length and where it's supposed to be. We then move on to the Volkmann fragment. This is done actually, this clamp was passed through the anterior incision percutaneously around in order to reduce the Volkmann fragment. We then can get our medial fragment in the ballpark, and then reduce our central comminution, which you can see here. And how do you access that? We have to flip open your Chaput fragment, and then that gives you direct visualization into see that central impaction. This is what's shown here. So the Chaput's opened up. There's a line right here. It's a little subtle, but there's a line there that is on the left image. That's the central comminution. That's a little bit elevated, and then we push that down and reduce it and hold it with a couple K wires from the intact tibia, and that's what you see there on the lateral view. If you don't reduce that first, then you'll have this discontinuity in the middle of the joint. Once that's done, then you can put your Chaput fragment back down. Now you've basically reduced the articular block. So this is what it looks like. It's provisional fixations with clamps and K-wires. This is just a nice schematic from the book up in Seattle that they did up in Seattle, just showing kind of the wire placements to hold each of these fragments as you're moving along. But you just want to make sure that you've got wires that are crossing each of the major fracture lines. This is sort of the definitive fixation I would typically do. So almost always do an anterolateral distal tibia plate. This plate gives you a row of screws that kind of secure the articular block together. And it also allows you to secure that articular block to the shaft. However, I think a key point of discussion is this medial buttress. So in this case, this was a valgus pilon fracture. So I did a went relatively light on the medial buttress. So this is just a 1/3 tubular plate with a couple of malleolar screws. And that does okay for him and holds him in appropriate alignment, and he goes on to heal. This is him a year post-op. His joint's holding up reasonably well, and he's functioning and back to work. But not all cases are the same, and that's why I wanted to shift into the kind of the third major mode of failure, which is the metaphysis through metaphyseal non-union. So we'll come back to that case that I showed at the beginning, which was this really comminuted C-type pilon fracture. And how do we approach this case to prevent? I think we all agree this is a higher risk case for metaphyseal non-union. So the question is, we probably aren't going to be able to just do a 1/3 tubular plate for this one. You can see it's got on the CT scan the same classic fragments. The big difference is really just that instead of a valgus pilon, it's a varus pilon, which means that all that energy really went into the tibia and created a highly comminuted injury pattern. So our approach to the articular surface is much the same. So we sequentially reduce each of those fragments until we feel confident that we've basically converted it from a C-type fracture to an A-type fracture. And now we've got to link this articular block to the shaft. So the first thing is you have to make sure you get it well aligned. In this case, I used, there was one medial cortical piece that I was able to put in place and get that alignment restore that alignment, but there's still a large bone defect there. And so the question is, what do you do with an injury like this? And like I said, it's certainly probably not a 1/3 tubular plate. So this is kind of the main final learning point is about avoiding metaphyseal nonunion. You have to recognize high-risk cases, which are these ones with really a large zone of comminution. Open fractures are particularly bad. And of course, with bone loss, then the risk really starts to go up for nonunion. So in these cases, you want to make sure, if you can, to add a rigid medial buttress. And if there really is bone loss, you can consider using an cement spacer and coming back and doing bone grafting at a later date. So in this case, I did a large medial buttress, which you see there on the far right image. So this isn't a 3rd tubular plate. This is a big, stout medial plate. And then I put antibiotic beads into that defect. 6 weeks later, come back and do an elective outpatient procedure to place some bone graft, which for me is a much more predictable course than to just hope that this large defect is going to heal. This is him at 2 years post-op. He ended up getting his medial plate removed, but you can see he's well healed. Medial plate was removed just because it was palpable and symptomatic, but he's doing quite well. Last and final point, this circles back to the first learning point about infection again. You put all this metal in there, you've got to do a really, really meticulous closure. I always try to get a good fascial closure. I place all the sutures first and then tie them sequentially to ensure I get the fascia completely closed, and then do all Gower Donati sutures to close the skin. And you keep the knots away from the flap side to really minimize ischemia of the skin of the flap. So just to wrap it up, these are the take-home messages. Stage treatment and good soft tissue handling are really the key to preventing infection. You've got to spend a lot of time with that preoperative CT scan and x-rays to understand the fracture so that you can choose the right approach and reduction sequence to get a good articular reduction and prevent post-traumatic arthritis. You want to make sure you understand the basic classification and implications for treatment. So B-type fractures versus C-type fractures, and how that influences your choice of approach and your choice of implant placement. And you really want to anticipate some of these high-risk cases for nonunion and make sure that you're doing adequate fixation or even stage bone grafting if necessary. Thank you.